So we're looking at all the aspects. Our reports tend to be like 12 and 13 pages long because we're looking at everything. We're looking at the mealtime routine at home. We're having the parents fill out a Pedi Eat to see if there's restricted diet. Do they have a pediatric feeding disorder?
Hi, and welcome to episode 336 of the Untethered podcast. Today, we have Karen Howarth joining us. Karen has been a pediatric occupational therapist for 25 years, specializing in feeding. She's worked in a variety of settings, including early intervention, the NICU, outpatient clinics, and for the past 13 years in the public school setting. She recently obtained her doctorate in 2023, and her research was focused on development and validity studies on mealtime screening tool for the school setting. Karen is also a new OT mentor inside Feed the Peds, and we're so excited to welcome her to the team. Welcome to the Untethered podcast. I am your host, Hallie Bulkin. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Karen, welcome to the podcast.
I'm so happy to be here. Thanks for inviting me.
I'm excited that you're joining us. So before we jump in and have you share with everybody a little bit about, who you are and your background, I just want to tell everybody that, you recently joined us inside Feed the Peds as our resident OT mentor. And we're so grateful for you and so glad to have you on the team.
I'm so happy to be here. It's been such a great experience so far.
Well, I'm glad to hear that. So share with everybody a little bit about, your background. Obviously, you're a pediatric occupational therapist, but share about your background, what you're doing now.
Sure. So I have been a pediatric OT for, this is going in my 25th year. I have only done pediatrics. I've worked in every possible setting, and including the neonatal intensive care unit, outpatient clinics, early intervention, and most recently I've been working in the school setting in North Carolina. And I have been specializing in feeding for the past 20 years and through that journey. And about 2 years ago, I finished my doctorate in occupational therapy from Columbia University, where most of my research was on developing a mealtime assessment tool or screening tool for the school setting, because the role of OT and feeding has not been studied in the school setting. It's basically in homes, clinics, hospital settings, but yet there's no information on addressing mealtime challenges in the school setting where kids are spending 6 to 8 hours of their day, 5 days a week.
Yeah.
So I have a wonderful husband, and I have a 6.5-year-old who just started first grade today.
Oh, congrats. I have a 7-year-old going into second grade in about 2 weeks. So yeah.
Awesome. Yes.
Fun times.
Mm-hmm.
Oh my goodness. Okay. So tell us more about this, because you're saying, so it hadn't been studied at all, OT feeding in the schools. And so you did research to basically create a screening tool, right?
Yes.
Okay. So can you share a little bit more about that? Like, what does the screening tool look like? And is it different in the school setting, right, than like a clinic, let's say?
Sure. I'll be happy to talk about it. So it's called Mealtime Screening for Schools, or meals for short. So MEALSS. I do have my own website now, that the tool, is available electronically, as well as like hard copy. Being a member of the mealtime support team in the county that I work for, there was not really a whole lot of investigating or considering the environmental, the cultural factors, or the child actually participating in their meal. We were so focused on the physical parts and the biomechanics of eating, and can they feed themselves? Are they chewing safely? Are they, do they need a modified diet? And we weren't really looking at the engagement piece. So I saw this gap. And when I went to get my doctorate, I was like, this is what I want to focus on. So I developed a screening tool, And it looks at feeding performance skills, which is kind of, can they set up their meal? Can they feed themselves? How much assistance do they need? It also looks at the environment and context factors. And then the third category is it looks at mealtime behaviors. And it's a quick screening tool. Right now, it's geared for occupational therapists of any level of experience. And it can be a screening tool for, okay, these are areas that are supporting or inhibiting mealtime participation in their academic environment. And from there, there's this tool manual and also guidance on next steps. So if you find like the environment is one of the inhibiting factors, can the environment be easily changed? Can it be modified? If there's performance skills, can there be modifications easily made, or do further evaluations are needed? Maybe in the community, maybe within the school setting, do IEP changes need to be helped? So it's kind of a stepping stone for next steps when there's a mealtime concern or mealtime issues. And so my plan is, and my hope is right now it's based on ages 5 through 10 years old, but I would like to extend it to secondary school age as well as the preschool school age, and in hopes of making it multidisciplinary as well.
I
So
love this.
yes. So
Yeah,
it's pretty quick. It's an observation. It's a guided observation. So there's a checklist. I believe there's 16 or 17 questions. You can write comments about it. Can be subjective because what you think might be inhibiting might actually be just a compensatory strategy for the child, and they're still able to participate effectively. But it takes the length of a observation of a meal. So it takes in consideration all of those things and, that collaboration with disciplines afterwards. So if you're noticing, really difficult time managing foods or needing a modified diet, it's like, I really need to get in touch with a speech pathologist about maybe the child needs a modified diet while they're at school or they're really struggling, or we need to do some more education of the IEP team or the classroom staff. So that's in a nutshell.
I love that because, a lot of people know that I've created like a screener now. I haven't done any like research on it or,
Mhm,
it just kind of was like, hey, I feel like we need this like quick thing that helps us figure out if we need further assessment. But,
mhm,
while we might look at a little bit of the environment factor, it's really in behavior is really more so than the environment, to be completely honest.
mhm,
I think it's very more so, it's much more geared at the like sensory oral motor skills, right?
mhm.
Which you're kind of like,
Yeah,
this is where we were hyper focused. We need to be considering all these other things. So
right.
it sounds like, you kind of captured all of that, which is amazing.
Thank
Um,
you.
I also think it's interesting too, because, I started in the schools
Mhm,
and I was in the preschool. It was called PEP, preschool education program in the county that I
mhm,
was in. And I really wanted to go into the infant and toddler program, but they wouldn't let me do that right out of grad school. So I was the only person in the county where they let me split my time between two of the preschool programs. Most people had like preschool for like one little period of their week, and then they had like elementary for the rest.
uh-huh,
And I was like, no, no, I don't want to do like speech, language, reading, writing, like all that stuff. I want to do feeding. Like I want to do
mhm,
the stuff, and I want to do it with like the little ones. I only want to work
mhm,
with the little ones, like birth to 3. I was like, birth
right,
to 5, I could do. So,
mhm,
anyways, it let me start in the preschool population. I split my time between two schools. It was very interesting because in one of them, they had just started the PEP program and nobody knew what we did. They didn't understand why we were there working with these 3 to 5 year olds. And also, feeding was like not a thing.
mhm,
And then I had the kids in the other school, and there were two schools, up county one and down county one school, where it's a self-contained school and goes K through 12, or through basically when these children graduate from the public school system
mhm,
and move onward. And you get a lot of your children who have more severe diagnoses and really need to be in those self-contained classrooms, but the PEP program happened to be housed there, and they had all different levels of the program. And some of these kids would go on to the general, education curriculum in a different setting. So in that school, everybody seemed to understand what we did, but I was still told, no, no, we don't do feeding. And I was like,
mhm,
this makes no sense. You have to eat to access the curriculum. And I'm pretty sure legally, I mean, and I was like fresh out of grad school back in
mhm,
2009. And like,
mhm,
I was like, I'm pretty sure, yes, like legally, you can't not give these kids support. Come to find out. So a therapist goes on leave and I inherit her caseload. And she had a caseload of children who were non mobile, who were all in a classroom together, who all had aids. Most of them had 24/7 aids with them.
Okay.
And they all had feeding goals on their IEPs. What do you know?
Much to
So I
your
was like,
surprise.
it's like, wait. I thought we didn't do feeding here. And like, what about all the kids in the other classrooms who
Mhm.
also need the sensory oral motor skills?
Yeah.
Okay, cool. Got it. So meanwhile, I am like thrown into this room where I'm watching children with cerebral palsy who are in a wheelchair, who really don't have a lot of mobility that they can control. And, not all of them, but most of them. And I'm watching like an aid or a feed down this kid's throat. The kid's head is like the neck is in hyperextension. And I'm
Mhm.
just going, I don't know anything, but I know that's not safe. And I just immediately from that point, like threw myself into as much continuing education as I possibly could. And that was my introduction to the schools
Yes.
until I then left after 2 years, went to infant and toddlers for 1 year, did do
Mhm.
feeding at infants and toddlers, but mostly the OTs did it. So it was usually a co-treat, and then
Right.
left the schools altogether. So
Yeah.
anyways, that's my experience. But I know just from speaking with so many others that like feeding is not commonly addressed in the school setting. And
It
so
isn't.
tell us, like, I'm curious to just share with everybody, like, where are you located? What school system are you in? Is this something that any child can access, or does it take a lot of advocating where you are?
So, I'm in Raleigh, North Carolina,
Mm.
Wake County Public Schools. We are kind of making pathways because we have other districts across the nation and within North Carolina reaching out to us, wanting to know how we set up this multidisciplinary mealtime team. We're called MST, Mealtime Support Team. And right now it's speech, OT, and physical therapy. And I kind of had the opposite experience of you. Like, I didn't start in the schools. I started in inpatient acute care, then went into specializing in like cardiac infants,
Wow.
and then into the NICU. And so transitioning to the school setting was a big mind shift for me because I had such a medical base and
Yeah.
foundation. So having to shift that into an educational frame of reference was a big challenge for me because I'm like, I'm just gonna, and also like your new therapist, you're like, I'm just gonna fix everybody. Well, you don't fix people. You don't fix people anymore. Like, get away from that mindset. And when I do some lectures and teach a couple of like course sessions at higher academia levels, I was like, you don't fix people. It's in our nature that we want to fix it, but don't meet the child where they're at. What are the goals for the family? What are the goals for the child if they're able to express it? Um, so we started this team about 5 or 6 years ago, and it's been building an airplane while we're flying it. So because there is no gold standard
Yeah.
to reference, we've reached out to other people. I know, like, we've reached out to Emily Homer because she does a lot in the school setting, and we've used some of her framework stuff. And then I decided to go back and do more research for my doctorate because this is such a huge issue. Um, so we've had to go through a lot of policy, a lot of procedures. And it has to be educationally relevant. So we have to explain to parents, like, oh, no, you're not just going to come to school and get your feeding therapy there because we're taking an educational frame of reference. Of course, we're using medical knowledge, and ITSE levels about diet recommendations or if they need thickener, but this is based on community medical knowledge, such as, swallow studies and, in ENT or G tube feedings and everything like that. We can help them access their curriculum, making sure that they get their adequate nutrition and hydration, but we're not doing sensory based feeding therapy.
Yeah.
And a majority of our cases lately have been ARFID and picky eating. And it's difficult because of course you want a child to eat more than just beige foods and tortilla chips all day long, but if it's enough to sustain their energy so they can participate in their classroom, then we really can't intervene too much. So right now we are set up, our mealtime team is set up for um, children who are accessing special education. We are operating through the IEP process, and we are part of the IEP. And children who have previous feeding difficulties, we can get referrals to complete a mealtime evaluation, and then we make recommendations based on that. Of course, we are in collaboration with community providers to make sure we're not confusing the child and that we're adhering to all the doctor recommendations and all the strategies that they're doing at outpatient. We're just not working on a lot of times progression.
Yeah, that's it's very interesting. That was one of the things that I like couldn't do it. It's one of the reasons why I left. I was like, I feel like I can do so much more for these kids
Yeah.
and that my hands are so tied.
Hmm.
And,
Yeah.
we have a bonus training that I think we still give. I have to check yeah, we do. I was just checking Kajabi that we give to anybody who takes Feed the Peds. And it's basically dysphagia, feeding and swallowing in the schools because
Hmm.
one of our initial co-creators, Kristen West, who was with us like
Hmm.
5 years ago, she has a program like this where she oversees the program. I can't remember if she's in Pennsylvania, maybe. But she oversees it. And so she basically goes in, creates the program, kind of trains the team on how to
Hmm.
implement. And it sounds, you don't know if this is similar to like
Hmm.
what you guys are doing. But she was very in the know with all of like the, legal aspects
Hmm.
of getting something like this in place for a child. But I
Hmm.
think it's really incredible and important what you highlighted that, even though we are giving these children access to these services in the schools, it looks very different than
Hmm.
your sensory oral motor feeding therapy that they may be getting any more medical type of model, be it a private practice, outpatient
Hmm.
hospital setting, and whatever,
Hmm.
so that people really do understand that it does look different.
Yes. And it is, a lot of us on the team have, 15 to 20 years experience and came from a medical model. So it's hard for us to turn off that hat of thinking at
Yeah.
times, but we're trying to shift it and utilize it because, all right, we know that this child is not eating safely. So
Yeah.
how do we keep them safe at school?
Hmm.
Um, and then there's different frames of thought. Like the parent might not agree. And it's like, you know what? You can feed them whatever you want at home, but at school, this is what's safest for them. And if you're worried about advancing their diet or progressing them, there are certain cases where we will develop chewing goals or oral motor goals to get them to a more age appropriate diet level. But that's not the common, it's more of a rare case
Yeah.
situation. So, but yeah, it takes a lot of mind shift. And we're like,
Yeah.
okay, well, now that we are been officially been told by admin that we are part of the IEP process, those boundaries were set for us.
Yeah, educational impact. Those
Yep.
were that term right there. It's like, is there an
Hmm.
educate and is there
Yep.
more of a 25% delay causing an access to the curriculum and their
Yes.
daily da da da? And it was like these things are so forever burned in my brain. And I have not worked in the school since 2012. So
Okay.
if that tells you anything,
Yeah,
yeah,
yeah.
yeah,
What's nice about our little mealtime support team is that we are not required to determine eligibility. There's other components. So I believe there's 16 different areas of eligibility, and there's different testing and assessments that need to be completed when you're considering those areas of eligibility. Mealtime is not one of them. So that's a caveat for us, that we're not required to determine eligibility. We're just kind of like another related service bonus to address that part of it, the safety part of it.
yeah, that's nice. 'Cause I feel like
Mhm.
part of the eligibility component was, well, oh, in order for them to get this service, they have to be on SLP service. And in order for it's like,
Mhm.
well, who made
Yep.
that stupid rule up? Like,
Yeah. Yeah. And every state's different. Every
yeah,
state's different. The things that there's disability states and there are non-disability states. And so
yeah,
it's very different. Sometimes we get children from northern states like New York and New Jersey, and they're coming in with all of these intense goals that are being served 3 times a week, and we're like, "Wow, yeah, maybe once a week down here with how North Carolina system works." But,
yeah.
yep.
Yeah, no, there was a lot of that discussion back when I was in the schools too, where it's like, it would be nice to give this child 90 minutes a week and see them
Oh,
three
oh,
times
yeah.
30, or to
Yep.
even do 2 45-minute sessions a week. And honestly, in some cases, we were able to argue that the child really needed that.
Mhm.
But those were more severe,
Yes.
cases.
Yes.
Um, yeah, it was usually a one time a week, 30 minutes
Mhm.
or 60 minutes or 45 minutes or whatever the case was. And yeah,
Yeah.
it all came down. And unfortunately, which is completely illegal and they can never tell you this, but it all came down to staffing. It all came down to the
Yep.
availability of what services they had available to
Yep.
fill. Because if they put
Which
it on the IEP, they're legally required to fill it. So they would try to just keep it
absolutely.
off the IEP.
Yeah, which is unethical, but
Yes.
that's
Yeah. And
another
which is also another reason why I was like, I'm out. I'm done. I don't like this place anymore.
I
I
totally get
don't
that.
take no well.
Yeah, I don't either. I don't either, but
I just don't do it.
I've learned the soft language and have come a far way and like, no, I want it my way. And so, just it's a lot of mind shift and
Yes.
not, not taking no for an answer, but also not pushing back to the point where, you're going to lose your job.
Right.
So,
Exactly. Exactly.
but there's that piece of it. So, yeah, we have something really special and I'm glad to be a part of it.
Yeah.
And trying to educate more, in our profession about the importance of addressing it because it's such a huge thing. It's so
Yeah.
huge. Um, and I know you knew this, but the honest, I presented at the North Carolina Occupational Therapy Association conference this past fall, and then I also presented at the American Occupational Therapy Association national conference in the spring about this importance and the work that I am trying to do in my spare time.
Were people like surprised to hear about it or people kind of like, oh, that's a thing? Like,
Um, Mixed. Like some people are like, "Oh wow, yeah, there isn't anything out there and this really needs to get addressed." And oh, my district just tells us to stay away from it and don't do it. But what do we do with all these kids with it's almost a pandemic or epidemic with the picky eating and ARFID diagnosis and even PANDAS is coming up a lot too,
yeah,
with diet levels and things like that, that it's you can't help but not address it.
right.
If a child can't make it through their day because they're not safely eating or they're not getting enough hydration and nutrition, like that's not fair to them if we're not trying to provide free and appropriate education
Yes.
and them accessing the curriculum. So we have to intervene. Not
Yeah.
like, oh, we're just going to put everybody on modified day and their parents can feed them when they get home. That's not fair either or
Yeah.
equitable.
So how do you address it across like the various settings? Because obviously you're not controlling what's happening at home and what happens at
Mhm.
school. Like you've kind of said, well, we may have different goals at school than the parent may have at home because it's more about
Right.
accessing the
Mhm.
curriculum and maybe they have their preferred food all day, but it
Mhm.
gets them through the day, right?
Right.
Yeah. Is that like a big conversation?
It is. And it also depends on the family and it depends on the child. I mean, we do offer, I don't know if you're familiar with like the multi-tiered systems strategies, MTSS. So we have developed kind of MTSS strategies at the different tier levels with meal times. And we're trying to eventually create a curriculum, especially for those preschool classrooms,
Hmm.
so that mealtime and positive mealtime exposures become part of the day.
Oh, I like it.
And yeah. So I mean, that's a huge goal. That's probably maybe 10 years down the road, um, but I mean, some parents are like, I want all the help, and we're happy to provide them resources. And some kids insurance won't cover it or schedule is too crazy and they can't access the feeding therapy. So we should provide them with as much tools as possible and make sure that there's at least some consistency in the strategies that are being used at home and used at school. So even if it's not diet level, like, oh, well, I give him steak at home. Well, he's not really safe to eat steak at school. That's fine, but let's use the same visual cues. Let's use the same verbal cues. It's the same prompting. If they're overstuffing their mouth, like we're using the same verbiage, we're using the same visual cues. So we will often provide a set for the classroom as well as a set for home. So there's that consistency for the child, but it's heavily child dependent and case to case. And then there's parents that don't comply at all and they've agreed to a certain diet level and that we have felt that and this physician has signed off on it and they're sending the child to school with food that is not safe.
Hmm.
And then we deal with that ickiness of, hey, we didn't feed what you sent in because it doesn't meet the criteria that you agreed upon. It doesn't meet the medical statement. So we do run into those situations as well where there's continued noncompliance. And that's when we get admin involved, because it's a huge safety issue. And we
Yeah.
don't want, child shouldn't be eating, beef jerky steak and they should be on an easy to chew diet. We're not going to give that to them at school because if they choke, then the school is liable.
Right.
So
Fun times.
yeah, yeah, let alone IEP meetings.
So then explain for everybody
Mhm,
because, some people might be going like, okay, I hear you talking about the differences in school versus like a clinic setting or
mhm,
outpatient setting.
mhm.
So how are you assessing these mealtime difficulties in the school setting, right? Because it almost sounds like you still have to do more of a medical approach and an assessment, right? To
Oh,
understand what's safe, what's not safe. And
yeah.
are you guys assessing or are you relying on outside assessments only? Like, what does that look like?
Oh, so no, we're definitely, if the child gets referred and a mealtime evaluation is signed for and consented to by the parent, we conduct a full evaluation. Depends on the child. OT, we tend to handle the lower tech, less complex seating. But if it's a child that's more medically involved, more medically fragile, and they're requiring more complex seating, we do have physical therapy come out with us. Sometimes we're seeing these kids over a span of like 3 and 4 weeks, because we're trialing different things. We do also take the information, like any medical information, GI history, um, nutritional supplements. Are they growing? Is there any history of aspiration or dysphagia, any history? So we take that all into account. But when we go out, we are physically scheduling during a snack time, during breakfast, during lunch, whatever they eat at school, what their current diet is. And prior to the evaluation, we staff are filling out a notification of mealtime concern that they check mark, like they're concerned about the child's positioning or they can't feed themselves. So we're looking at all the aspects. Our reports tend to be like 12 and 13 pages long because we're looking at everything. We're looking at the mealtime routine at home. We're having the parents fill out a pedi eat to see if there's restricted diet. Do they have a pediatric feeding disorder? Um, Also all their medical history. We get all of that. And I look at OT, we look at self-feeding, we look at sensory, and positioning and equipment needs, and then we make recommendations based on that. So we are doing a quite comprehensive evaluation.
Yeah. No,
So
that's helpful to understand because I think it's
yeah.
like,
Hmm.
yeah, knowing that you guys at least are gathering all that information, you have
Yes.
obviously the
Yes.
comprehensive eval and everything to kind of back
Hmm.
what you're doing is I mean that's great. I think that's great that you guys actually get to do that and you're not just depending on outside, you
Yeah.
know,
Yeah.
input. And
Right.
then so you mentioned kind of the multidisciplinary approach at times when needed for assessment. Do you
Hmm.
also ever take that approach? Are you able to take that approach for feeding like intervention?
Oh,
Um,
absolutely.
yeah.
Absolutely. Yeah. 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 So once we complete our eval, and if we are recommending a modified diet, we always send a copy of our report to the child's pediatrician so they can look over what we saw in the school setting, because what might be going on at home and what might be going on in school are sometimes extremely different.
Mhm.
And also taking into all those cultural factors, and potential language barriers. And sometimes there's unsafe practices going on at home. And then we will write up a mealtime support plan, and it's interdisciplinary or multidisciplinary. And we will both train school-based staff, but it's often a mutual effort. I would say 99% of all the cases that we see are speech and OT.
Okay.
There is PT involved for the more, but I'm on almost every single evaluation case or every
Yeah.
single case that comes our way. Um, and we will look at, okay, what kind of sensory or pre-feeding strategies need to happen prior to that? Do they need Z-Vibe? Do they need some heavy work? And then the speech therapist might be facilitating more of a age appropriate chew pattern, and I might be working on the self feeding part. So it's very much a collaborative effort.
Yeah. Okay. Here's a I don't know if it's a loaded conversation or not, but
Mhm.
um so I feel like there's been a lot of discussion about being, being culturally sensitive
Mhm.
and obviously very important to
Mhm.
consider those cultural factors, to consider, because so when you guys are doing these evals, are you also going into the home and doing the observation there? How are you gathering that data?
Depends on the kid. We're typically
Okay.
not
Okay.
because it's educational relevance. We want to see the child eating in their educational environment.
Mm-hmm.
However, we do frequently, if a child is not eating at all at school, or we are really the classroom or the team is really struggling with getting the child to eat at school, um, we will reach out to the family and be like, "Hey, can you send me a video of how they eat at home?" And that's really, really helpful. So
Okay.
we can look at and attempt to set up things as similar as possible, as long as they're safe and they're not making us roll our eyes with, oh my gosh, they're just shoving that down that child's throat. Um, so we do sometimes, if a child has just moved to the country and they're new to the county, um, and they haven't been placed yet because they don't know what is the best placement or eligibility, I have done some home evals.
Okay.
Um, for those kiddos, to try to establish a safe diet for them for whenever they do get placed into an appropriate classroom
Yeah.
or
So I
school.
guess so I guess the follow-up question to that is more than like what are you doing, to
Hmm.
make it so that you're sensitive to any environmental or cultural,
Hmm.
linguistic, all the
Hmm.
different kinds of differences, things that can be
Hmm.
happening.
Hmm.
Um, because if, let's say, a parent, I'm just imagining a situation where a parent is doing something that's unsafe,
Hmm.
but maybe it's a cultural thing, like the parent feeds the
Right.
child and
Right.
it's seen it, right?
Hmm.
And you guys are going, but in feeding the child, the way that you're doing this is unsafe. Like, how are you navigating these things as a school based?
Very carefully.
Yeah.
Very carefully. It depends on the family. Because we've had a lot of cases where, like, I have no problem getting them to eat at home, and they're really just kind of shoveling it in, and they're force feeding. And I was like, okay, well, we are very sensitive and be like, I'm so glad that that works for you at home. However, that is not a practice that we can get behind in the school setting, because we're trying to give the child some autonomy and some control, and we want them to be safe. So we're respecting that, and just there are a lot of cultures where uh, parents will feed kids and feed them and feed them, feed them, and then they send them to school, and they're like, I want them to learn how to eat by themselves. And it's like, that's great, we can work on that, but I really would love if you could pick some times to work on it at home as well. It's kind of like, some parents were like, I want you to fix my child in one therapy session a week in the private sector, and not carry over anything at home. So
Yeah.
there's that carryover factor.
Yeah.
And some families we get through, and then there's other families that we don't. And then we kind of rely on the admin to help direct us. And unfortunately, there has been some cases where the practices that are going on at home are very, very unsafe. And we have to get the school social worker involved.
Mhm.
And we have to discuss with the pediatrician, like, do child protective services need to be involved, because the way that this child is being fed is unsafe and forceful and
Yeah.
not safe for them. Um, so every case is different, and we do what we think is within our licensure, what is ethical, and what is best for the child, because that's our main focus. But in terms of like foods and cultural, there are definitely some cultures where it is acceptable for the child to be fed. And if the child won't eat anything unless they are fed by an adult, then we have to make some accommodations in the school environment for them to access their education.
Mhm. Yeah. Thank you for sharing that, because I just know people are probably, though, like, some of our listeners will be thinking, well, how do you go about that? And like, what do you do in these tricky situations? And I mean, I know in infants and toddlers, there was a time where we walked into a home and the child was rolling their little car across weed on the, it was like, just run right through the weed, right across
Yeah.
the table. And I was like, oh,
Mhm.
cool. Okay. That's a fun way to
Mhm.
start this eval. Right. And then we look
Yeah.
over and like the 4-year-old is cooking themselves mac and cheese on an open flame. And I'm like, the kid can barely reach the pot. This is
Yeah.
not
Yeah.
okay. Well, this is
Mhm.
a call to CPS, and it's
Yep.
unfortunate. That's obviously for us, not obvious, but for us, that was not the bulk of the cases.
Mhm.
But, you always get not always, you occasionally get cases where they're really tricky to navigate. And I
Yes.
think when it comes to feeding and it comes to cultural differences and it comes to just family differences, sometimes it's not even a cultural thing. It's just, this is
Mhm.
how this family operates. And we kind of, but when it's unsafe, we
Yeah.
then have that ethical obligation
Yeah.
to
We do.
unfortunately take certain actions. So, and I know especially with feeding these little ones, like it's,
Well, and they may have been premature, and this feeding issue has been long going, and
oh yeah,
it's a feeding battle. It's a huff, and I tell parents a lot. I was like, this is a marathon and not a sprint.
yeah,
And then there's going to be lots of hills and valleys in this journey. Um, I mean, and when you're a parent and you have a child with feeding difficulties, I mean, you're unable to meet their basic needs, and there's this tremendous amount of guilt
yep,
that a lot of parents experience. And I think as a clinician, whether you're school-based, private, hospital, wherever, you have to take that into consideration because there is a lot of parental guilt going on. Like, my child doesn't feed well. It's all my fault. Like, it's my fault that they were premature. It's my fault that they have a feeding tube. And there's so much guilt
yeah,
that you have to be extremely sensitive to that and meet the parent where they are.
yeah,
We do a lot of education, as much as possible, a lot of communication with parents, and we put in our best effort. And at the end of the day, I try to rest my head on, I did the best that I thought I could do for the family and the child.
yeah. Thank you for highlighting that because
Yeah.
I was going to also kind of mention that, it's, we never know what experience they've had to date aside from what they share with us, which is not always the whole picture.
Hmm.
A lot of the families that I, my team and I have worked with in the past, and now they, they all have their individual journeys
Hmm.
and there's so much parent guilt. Like there's so much, I can't tell you how many parents have said to me, what did I do wrong? Like, when did I mess this up? Or like, like when do you think this started, or like what do you
Hmm.
think I did? Was it something I did in pregnancy? Was it something I did, I'm like, no, like it's not that cut and dry. And
Hmm.
unfortunately, but as a parent I get it because I've had the kid who has been the picky eater, who's,
Yep.
1% on the weight chart her whole first year, who struggled to feed, breastfeeding. It was awful.
Yep.
And, as much as I knew deep down it wasn't my fault, I still was like, I have one basic goal in life right now. This
Hmm.
is keeping this baby alive. Like, I got to
Yep.
keep her breathing and
Yeah.
feeding, like, and peeing. Like, I got to,
Yep.
yeah. And so
Totally
when you
get
can't,
that. Totally get that.
yeah,
I have a kid. And she was small. I had to get induced because of preeclampsia, and it was a very traumatic birth. And then it was like she was so tiny. Breastfeeding did not go well. Didn't happen. I exclusively pumped for 9 months for her, and it was exhausting. And then I'm like, oh, I'm feeding specialist. She's gonna be great. And she was feeding herself with utensils. And then we hit the picky eating phase, and we're still in it 4 years later. And I'm
been
just
there.
like, so I get it. I get it. So just, I think it's really important for any clinician just to be sensitive to that. And as much as you want to judge, I mean, a lot of times we get cases and I'm like, the kid's not eating at school. And I asked the parent, I was like, do they eat with an iPad at home? And they're like, yep. And I was like, I hate to do it, but sometimes we get kids to eat if we get them access to electronics.
Yeah.
It's not a long-term fix, but it's like if we can get them eating successfully at school to keep them at school so they don't have to have a modified day, then maybe they need this accommodation for a little while until they can get used to the mealtime routine at school.
Yeah.
So,
Yeah.
yeah.
No, I like the flexibility in it. I think it's,
Mhm.
more people need to hear that because I think people are so hard cut on like, no, you don't do this and you don't do that. And it's really about like, well, what is the best thing for this child right now?
Mhm.
And then how do we maybe adapt, how do we
Mhm.
adapt to the current needs? And then how do we
Mhm.
phase maybe some of these
Right.
crutches, or
Right.
supports out, not a
Yeah.
crutch, but
Yeah.
supports out. So I mean, it definitely sounds like you do a lot of education with families for sure.
Mhm.
I'm guessing you probably do a lot of education with school staff as well. Is that a
Yes.
big component of the program?
Yes, we definitely have like our OT department is over 80. So we have over 200 schools in the county I work with. So yeah, we do a lot of education with them, and a lot of it is building competency at the school-based level. So we are coming in as kind of like more seasoned more experience. I don't want to say expert because I work with some people who are just as talented as I am. I just, happen to fall into being one of the leaders on this team. Um, and so it's a lot of education and meeting the clinician where they're at. So there's some new clinicians like, oh my gosh, I don't want to touch feeding. I'm so scared. Can you come out and see this kid with me? I'm like, sure. And then, we'll share a lot about, I've in-serviced about, my tool and that made that accessible to the entire department to use. And then speech and physical therapy also do their throughout the year. So we have professional learning teams where we meet every so often and review any of the latest literature or send an email and say, hey, we don't need to have a meeting, but this is really cool information.
I love that. And I think that's so critical, so crucial, so needed. I mean, there's
Hmm.
so many therapists out there, whether it be in the schools, because we get people who come to us and say, well, is Feed the Peds, like, will it be for me? I'm in the schools, and we tell
Hmm.
them like, look, like you need to know this information. So yes,
Hmm.
it's for you. How you deliver it in the schools might look very different than in
Right.
a clinical setting, a
Hmm.
medical clinical setting, outside of like a educational setting.
Yeah.
But we do tell people, a lot like, yes, it's beneficial. You need this
Hmm.
information. It's very foundational. And so I love that you're also helping to kind of guide and educate these aspiring feeding therapists because, there's so many of them that are out there and they want to do it, but they're so afraid.
I know. And that's that was along with, trying to fulfill that gap that I noticed in the research with my doctorate is I I want to be an educator. And I'm so motivated to inspire the next generation of OTs and feeding therapists. And so when the opportunity came to join the Feed the Peds, I'm like, yes, this is this is my this is a definite plus in my book because
Yay.
I want to inspire and I want to help and guide um and teach to the best of my ability.
Well, we are so excited again
Mhm.
to have you on our Feed the Feeds team. And thank you again for joining
Thank
us.
you.
Is there anything else you want to share before we start to wrap up today? Anything else you want to share about like meal times at school?
Um, Not that I can think of, but I'm sure there might be questions coming through. So feel free to reach out to me and be happy to talk with you. I do have a website. I don't know if that you could share that. I
Yeah.
think I can share that with them. And
Yeah,
there's also,
mealsandschools.com.
yeah,
Yep. And
mealsandschools.com.
we'll put that in the show notes so everybody has access to that as well.
Yeah, yeah. And I may be doing like an informational session in the coming months when I can find some time
Yeah.
um about
Amazing.
what meals is about and about OT's role in the school setting with mealtime challenges.
Love that. Well, thank you so much, Karen, for
Thank
joining me today.
you.
And again, for joining the Feed the Peds team. We love you. We're excited to have you.
I
And
love you guys too.
I'm excited for the future.
Yes, me too. Thank you so much, Hallie.
Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Thanks for listening to this podcast. If you found value in this episode and want to hear more of these MyOTOTS airway and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at HallieBulkin.com or pop over to @HallieBulkin on Instagram to get all the latest updates.